executive cardiologist and currently is the chief cardiologist and chairman in Medanta Mulchand Heart Center, New Delhi, India.
Dear friends, ladies and gentlemen, I'll try my best to be as quick as possible, maybe 10 to 12 minutes. I'm sure Dr. Krishna Rao just mentioned to me. The topic given to me is CKM, obesity, hypertension as a metabolic driver for HFpEF. Ladies and gentlemen, it's very, very common. It's a global tsunami today. The prevalence of CKM is 70 to 80% in our country. And if you see obesity, it's 44 millions in women, 26 millions in men. 84% of HFpEF patients are hypertensive. My objective is to highlight on morbidity and mortality benefit and drug intervention like SGL2 and GLP-1 receptor agonist. The definition of CKMS should be known to all of you. It reflects amongst metabolic risk factors with CKD and CVS with profound impact on morbidity and mortality. This is a very important slide. Stage 0, no risk factor. Stage 1, excessive dysfunctional adipose tissue. Stage 2 is metabolic risk factors. Stage 3 is subclinical and stage 4 is clinical. Obesity, if you see in Kerala, Delhi, Tamil Nadu is quite high and the overall prevalence rate is 5.21%. This is just to show how the obesity is prevalent in the various parts of our country. It's a real crisis. Hypertension, as you all know, is a global epidemic. Uncontrolled hypertension is 90%. It's a real challenge for us. Controlled hypertension, only 10% from Ministry of Health, ICMR, WHO. And we see here, the prevalence of hypertension is also rising in women as compared to men. The women are competing with men everywhere. And see the HFpEF. When I do 40 echoes every day, out of which I see 80 to 90% have HFpEF because they are hypertensive and obesity together. And this is the phenotype classification based on EF. HFpEF is more than 50%. And see the prevalence is highest in women as compared to men, and the prevalence rate is almost touching 10% after the age of 65. The common comorbidities are hypertension, obesity, and CKD. And see the risk factor. This is my first study, which I did in 2007 and published in Indian Heart Journal. And I've shown central obesity is the most powerful predictor of premature CVD. And the second component was hypertension, 78%. This is the hospital-based data. And this is just to show the prevalence now, more in female as compared to males. And the pathophysiology is very well known to you. As I told, there is a very minor difference in the metabolic pathway of obesity, adipose tissue dysfunction, inflammation, and endothelial dysfunction with stiffness. While in hypertension, it is increased afterload, left ventricular hypertrophy, and myocardial fibrosis, ultimately giving to increase and rise in the pulmonary wedge pressure. And we see here the level of leptins are high, they are adipokines, and the reduction of adiponectin are pro-inflammatory, pro-atherogenic, pro-fibrotic, pro-vascular stiffness, insulin resistance, and stresses at the level of endoplasmic reticulum, mitochondria, oxidative stress, and SNS activation. And this is just to see the hemodynamics, acute diastolic overload, systolic overload are common manifestation, ventricular dysfunction, atrial, autonomic dysfunction, and various other dysfunction are responsible for HFpEF. So HFpEF has not to be misunderstood or underestimated. As CKM, obesity, and HFpEF is a quadruple jeopardy. There is a stiff LV, stiff LA, stiff aorta, stiff pulmonary vasculature, and stiff peripheral vessels. This is just to show the inflammatory, neurohormonal, SNS activation, RAS, and NPS activation with mitochondrial, coagulation cascading, signaling, and increased level of leptin are all responsible. So hypertension, hyperinsulinemia, and all the factors which were also mentioned by Dr. Prabhakar involve all the effects specifically, not preferably to heart, and may cause CVD, heart failure, and diabetes mellitus. And we see here the outcomes are very well known to know by the study, CHARM study, as well as paradigm study have shown severe mortality and hospitalization in diabetic patients. And this study is a very powerful study from our own country. Trivandrum heart failure study has shown the readmission rate is high with HFpEF, and even the mortality is also high. And we can see how do we diagnose these patients. Ladies and gentlemen, echo and NT-proBNP are the cornerstone in management of HFpEF. No echo, no HFpEF. And no NT-proBNP, no HFpEF. These two parameters are very, very important. And here again, the European and American, we do LAVI, left atrial volume index, and we also do E by prime ratio, if more than 15. On the contrary, in the American, we see here BMI, hypertension, atrial fibrillation, and of course, age of the patients, besides the etiology. And this is what we do very commonly. We see the LAI, we see the LV mass index, and we also see the LAVI is very, very important variable. If it is more than 34 ml per meter square, it is a very powerful predictor of recurrence of AF as well as poor survival. We see here, this is very important, ladies and gentlemen. It is the fibrosis load. The fibrosis load is much more common in HFpEF, and that's how we call this as the atriopathy. So atriopathy, grade 3 and grade 4, are very powerful determinant of high mortality. We see almost every day in our hospital. And this is just to show the LA pressure at rest as well as the LA hypertension by exercise. And LA stiffness index is responsible for hospitalization as well as increased mortality. This is just to show the LA strain. There was a lot of discussion yesterday, but the message is very clear. Higher is the LA stiffness or higher is the mortality. So we have to make sure that the strain rate reduction is proportional to the LA size. Sometimes it is disproportional. The LA is enlarged significantly and you see only grade 1 MR. It is a stiffness load. We can't measure the load by echo, but by definitely we can measure the load by CMR. And if the load is more than 20%, then these patients have very, very high mortality. So ladies and gentlemen, the message is very clear. Reduction of LH trend rate predict mortality and morbidity HFpEF. And these are the studies which are done, no outcome benefits. Paragon study, TopCat, iPreserve, PEP-CHF, and CHAMP study. SGL2 inhibition has shown a very lot of promise in reduction of MACE rate, hospitalization, and the renal protection. We can see here the powerful studies are Soloist, Emperor Preserved, Imperial, Preserved Heart Failure, and Deliver trial. And Soloist trial have shown very clearly by Deepak Bhatt that there is a definite improvement in the functional benefit. Emperor Preserved the landmark trial with 6,000 patients and 26 months, and it has shown the benefits in primary endpoints as well as secondary endpoints in the form of CVS death and recurrent hospitalization with the heart failure, irrespective of gender, irrespective of the NT-proBNP or diabetes mellitus. And see the renal protection is higher with SGL2. If you compare the various studies like Emperor, Imperial, Deliver, and the Preserved Heart Failure trial, the mortality benefits are seen only with empagliflozin and dapagliflozin and not with ARNI. This is the Deliver trial. You're all aware of this. All the composite points, primary, worsening of the heart failure, hospitalization, and serious death and all-cause mortality are significantly reduced. And 23% relative risk reduction is seen in all the primary endpoints. What are the guidelines says? The guidelines says SGL2 recommendation is 1A. And we see here the Braunwald's corner, SGL2 and GLP-1 receptor agonists are shining molecules of century in the year 2025. And he also mentioned the SGL2 is like a statin of the century. Now, three pillars of the HFpEF by ESC, and very, very important, SGL2, non-steroidal MRA, and semaglutide, as well as tirzepatide. And you see here the lower slide panel. The wide spectrum is of GLP-1 receptor agonists in the present and the future, and SGL2, but not with phenylalanine. And see here the article from Circulation, very clear. If you want to see the improvement in the left atrial remodeling reversal, left ventricular remodeling reversal, and reduction in mortality rate and hospitalization, it's possible by combination of SGL2 and GLP-1. This is just to show the difference. I won't go to the details because of paucity of time, but we should know empagliflozin is superior in diabetes control and hospitalization and worsening of the heart failure, and the all-cause mortality is also reduced. This is by Chinese meta-analysis data, and IMPACT-MI trial has also shown in phase 3 trial reduction in mortality as compared to DAPA, which has shown only cardiometabolic benefit. This is STEP-HFpEF trial in diabetes and non-diabetes. They've shown the functional benefit by Javed Butler. And if you compare between the two, tirzepatide and semaglutide, the difference is very minor. Both of them have some kind of side effects, but the studies published are mostly with the injectable, not with the oral one. And reduction of A1C and weight loss is is seen to some extent higher with tirzepatide as compared to semaglutide. And these are all the studies published till now, a randomized controlled trial with tirzepatide. But the meta-analysis summary is very clear. Reduction of MACE rate, mortality, worsening of the heart failure, anti-proBNP reduction, and functional benefits. AI-powered algorithm you just heard from Dr. All our colleagues since morning, the answer is very simple. HFpEF care must target upstream drivers. AI enables us precision and timely therapy in these patients. We already published 3 books on the heart failure, hypertension, as well as atrial fibrillation. To conclude, ladies and gentlemen, health of millions at stake with CKM, obesity, hypertension, and HFpEF in India. SGL2, GLP-1 are the iconic molecules. Hit hard, hit early, hit safe, and optimize early before it's too late. My tribute to the pioneers, especially Anker, Butler, Nassif, Bhatt, Abraham, Solomon, and McMurray. And this you should remember, cardiometabolic health is blood flow vessels 1 kilometer per hour. The secret of living longer is again seen on this platform. Living well and longer is eat half, walk double, and laugh triple, and love unconditionally. Thank you very much for your kindness.